Hello everyone, and welcome to another video of the NEET PG Coach. So in this video, I'm going to be teaching you about how to read the chest x-ray like a pro. So as you all know, reading the chest x-ray can be a very useful skill, and it can be life-saving. For example, if you're able to detect a pneumothorax or a small lesion which could potentially be malignant, could turn out to be life-saving. And it can also help you during your exams, like in your NEET PG or in your next exams. Like if you've done really well in the other sections, some of these image-based questions might decide whether you get into the top 2000 or top 1000. So it can help you there. And it can also help during your internship and during your post-graduation. I guess you scan through different films. If you're well versed with some of these basic concepts, you'll be able to get a lot of pathologies right. And only slight effort is needed to understand the basics. Okay, so now let's get straight into the video. Just remember this point, only slight amount of effort from you is needed to learn the basics. So just make sure that you watch this video completely till the end. Okay, so this is a normal chest x-ray. I've told that this is a normal chest x-ray. And whenever you see a chest x-ray, there are certain things that you need to see. One is projection, then orientation, then penetration and rotation. So projection, what do I mean by projection? I mean to ask whether it is AP view or PA view. Okay, the standard chest x-ray is always PA. PA meaning posterior anterior. Imagine this is the back of the patient. I'm writing B here. This is the back of the patient, and this is the film. Okay, and here is the x-ray machine which is shooting out x-rays, and the x-rays come and strike the back of the patient, and this is actually projected onto the film which is placed in front of the patient. So that's why we call this PA view. Like it is going from the back of the patient, that is from the posterior end of the patient, to the anterior. So that is why it's called PA view. PA view. Okay. The AP view, as you can imagine, will be different. So this is the film, for example, and this will be the back of the patient. This will be the back of the patient, and this will be his front. And here, this is his front. Okay. So in this thing, as you can imagine, the AP projection, the X-rays are coming and striking the front of the chest of the patient, and his back is facing towards the film. So that's why this is called AP view. So it's going from the anterior part of the patient's chest to the posterior part. So that is as far as projection is concerned. So the standard chest X-ray is always PA. Okay, unless it's labeled as AP, it is PA. But sometimes it might not be labeled as AP also. So you need to know certain things to find out whether it's AP if it is not labeled like that. So here you can see the PA film. Okay, then the next thing that you need to look for is orientation. What do I mean by that? Always on top of the X-ray film, it'll be written right or left or something like that. So that is to help you become oriented with the film actually. So right means this side is right, okay, and if it is written left here, this side is left. Okay, so it's usually labeled the right side or the left side. Either the right side will be labeled or the left side will be labeled. So based on that, you can find the orientation of the film. Okay, and the next thing that you need to know about is penetration, like whether the film is over penetrated or under penetrated. For that, what you need to do is you need to look at the lower portion of the cardiac shadow. You can see the vertebral bodies here, right? You can see the vertebral bodies here. These vertebral bodies should be slightly visible, okay? They should not be fully visible, they should be slightly visible. On the lower part of the cardiac shadow, if you can see that these vertebral bodies are slightly visible, then you can say that it is a adequately penetrated film. Films can sometimes be over-penetrated or under-penetrated. This penetration is otherwise called exposure. Sometimes they might say overexposed or underexposed. And the next thing that you need to check is rotation. So you look at the medial ends of the clavicle on both sides and pick one of the spinous processes of the vertebrae and see if the medial ends of the clavicle are equidistant from the spinous processes. If the medial ends of both clavicles are equidistant from one of the spinous processes, it means that the film is not rotated. If one side it's close and the other side it's a little far away, meaning the medial ends of the clavicle, it means that the film is rotated. So you might need to order for a repeat X-ray film for that. So let's look at some visual examples. Okay, as I said, this is the posterior anterior view, and this is an example of AP view, anterior posterior view. So what is unique in the AP view? In the AP view, the one unique thing you can see is that the scapular shadow is projected on the lung field. Can you see the scapular shadow which is projected on the lung field? So that is one unique thing here. Can you see the scapular shadow? Yeah. The scapular shadow is projected on the lung field. So that is one unique feature of the AP projection. And also, it gives a false impression of cardiomegaly. So the cardiac shadow should occupy less than 50% of the transthoracic uh, transthoracic diameter. Like if the cardiac shadow occupies more than 50% of this diameter, we can say that that is cardiomegaly. But here, as you can see, it comes to be slightly more than 50%, but there's no cardiomegaly. That is because of the projection. Since the film is AP, anterior-posterior, since the patient is standing like this, and since the patient's heart is like this, a, a bigger a bigger image of the heart will be cast on the film since the heart is located more anteriorly compared to posterior. For example, if the heart is located, if the patient is standing with his back here, his heart will be here. So as a result, when the X-ray beams come, it projects a smaller shadow of the heart, cardiac shadow, in the PA view, whereas in the AP view, it projects a bigger cardiac shadow. So that is one. So one point is that scapular shadow will be seen in the AP film, and there will be a false impression of cardiomegaly. And as I said before, it is usually labeled, but even if it is not labeled, you should be able to find out the difference by using these 2 points that I just told you. And now this here is an example of an underpenetrated film. So why do I say that this is an underpenetrated film? To see the penetration of a film, what you need to do is look at the lower portion of the cardiac shadow. The thoracic vertebrae which are located here should be barely visible. If they are barely visible, then you can say that it is a normally penetrated film. But whereas in this case, you can hardly see the thoracic vertebrae, can hardly see them. So this would suggest that this is an underpenetrated film. An underpenetrated film is too white. Because it's too white, what is normal might appear abnormal. As in, there might be, you might see that there are some opacities here, but they are not actually opacities. That is because the film is underpenetrated and too white that you might mistakenly take something which is normal as abnormal. So that is the problem here. And the next one is overpenetrated film. So conversely to what I said, if you look at the lower portion of the cardiac shadow, and if the thoracic vertebra are clearly seen, like in here, you can say that it is a overpenetrated film. An overpenetrated film appears too dark. So you can see here it's too dark. And because of that, you may miss dense lesions. So to see whether a film is underpenetrated or overpenetrated, you just look at the lower portion of the cardiac shadow and see how clearly the thoracic vertebrae are seen. Normally, they should be barely seen, as in here, but if they are not seen at all, and if they are too clearly seen, as in here, you can say that there is an abnormality. If it is not at all clean, if it is white out, it is a underpenetrated film. and if it is clearly seen, it is an overpenetrated film. Also, the lungs appear jet black in an overpenetrated film, and they are whitish in the underpenetrated film. The next one is a rotated film. Um, just look at the medial ends of the clavicle and pick one of the spinous processes. If the medial ends of the clavicle are equidistant from the spinous processes, it means that there is no rotation. But if one side is closer and the other side is farther away, it means that the film is rotated, as you can see here. You can see here that both these clavicles are not equidistant from the spinous process. You can see that this clavicle is slightly closer compared to this. So this is a rotated film. So these are the basic things that you need to know in a chest X-ray. First, you need to look at the projection, whether it is AP or PA, and you need to look at the orientation, whether right or left, and you need to look for the penetration under or over, and you need to look for any rotation. And that brings us to the end of this discussion. In subsequent discussions, I'll be discussing about the different pathologies. So make sure to subscribe to this channel to get updates about those videos. Thanks so much for watching, and I'll see you in the subsequent videos. Thank you.